Hello, my name is Mark Brzezinski. I'm not going to go into my background. Most people know me for introducing OCT for imaging non-transparent tissue, particularly in cardiology, along with in collaboration with James Fujimoto. Today, I'd like to talk about TCFAs. If TCFAs don't lead to most MIs, what is a vulnerable plaque? The majority of the work today is going to focus in on paper that was published earlier this year in JAMA Cardiology 2019 by our group. And we're going to focus in on failed healing as being a risk factor for ACS, particularly failed tissue healing. Acute coronary syndromes may require a double hit of both rupture and impaired healing. And this is first tissue healing, and secondly, we feel strongly that long axial cores or shafts predisposed to poor healing. The situation is somewhat analogous to oncology, where after studying oncogenes for decades, it was discovered that 50% of all human cancers also had a mutation in the p53 tumor suppressor gene. Now, again, core or shaft length is a major risk factor as far as we're concerned for impaired healing and therefore ACS. And we're not talking about failed systemic healing mechanism. Why impaired healing with long cores will go in to some degree in this presentation, but there's going to be a follow-up presentation once an embargo on a journal article is lifted. Now, TCFAs have been very important, or it's been a very important definition in cardiology, but it isn't a vulnerable plaque. It's a predictor of progression to a fixed stenosis. So this isn't a novel concept. It was discussed in the paper outlined by Mann and Davis in 1999, but also more recently in proximity to the prospect studies, the Stone group made the statement, a clinically relevant definition of vulnerable plaque is a lesion that places a patient at risk for major adverse cardiac events, and then they went on to say death, myocardial infarction, and progressive angina. So we started looking at plaques longitudinally in around 2013. This paper published in 2014 along with Kishore Hajar of Geisinger was our first publication in the area. But we'll discuss this paper in a little bit more detail shortly. So we, like other groups, have been looking at plaques and cross-sections since the early 90s, trying to figure out what makes certain plaques lead to ACS. And this is just an example of a plaque and cross-section. But what we're missing here is that the longitudinal extent. This plaque could extend 0.5 millimeter or it can extend 20 millimeters, and they may have dramatically different properties. Showing the gross and OCT images of one plaque. This core is 40 millimeters long. It extends from the left main to the down the LAD. Now, we had seen these cores back in the 90s, but unfortunately we didn't make much of them. I actually remember commenting to Gary Turney, who was a student at the time, that they're very artistic. So it's not like we had, it came to us very quickly, but one of the characteristics of these cores is that they don't stay in one axial plane. They tend to rotate around, and you can see this in A, B, and C as it sort of turns around. It makes it difficult in a longitudinal OCT scan to catch the entire core length. Now, we've looked pretty extensively through the literature dating back to Patterson in the 1930s, and this is the only paper we found that substantially looked at plaques longitudinally, and this is by the Stone, Vermani, Muller, prominent scientists in cardiology, but they were looking for the relative distribution of TCFAs in coronary. So while they did a tremendous number of coronaries, they cut off the edges and they described cores in terms of volume, not in terms of linear extent, and even more importantly, were more focused in on the luminal surface area of the core. So their conclusions or hypotheses were more about distribution. So we've known prior to the prospect study that less than 20% of TCFAs lead to acute coronary syndromes, but the prospect study obviously was very important in confirming this, and I repeated that quote from the Stone group below. Now, in our 2014 work, it started with a patient at Geisinger Hospital who had 2 TCFAs during a stent placement, at one proximal, one distal, and they were undergoing OCT imaging. The stent clipped the proximal TCFA, which was contiguous or in close communication with a long necrotic core, while the distal one was not. The proximal one, blood drove in through the core approximately 5 millimeters, evacuated the core, and a clot formed distally. And so this started us thinking in this direction. And since then, not that we necessarily think that long cores, their major mechanism for affecting healing or increasing the likelihood of ACS is large-scale evacuation, but it is one of the potential reasons. Now, since then, a lot of groups have, or at least numerous groups, have started looking at the core length in their studies. And so when you look through their studies, you can see correlates with the length. And so this study done by Jing in the Journal of the American College of Cardiology, it was registry data, but at 2 years looking at non-culprit lesions, the ones most likely to result in a major coronary event were those associated with a long core. Now, in another important study in the Journal of Cardiovascular Imaging, they were looking at reflow with OCT, and that part isn't what we're going to discuss here, but if you looked at the two groups, no reflow versus normal flow distally, these were all patients that had an MI. The core length in these STEMI patients was greater on average than 12 millimeters, which is extremely long and consistent with our hypothesis. Now, there's numerous reasons why long cores will increase the likelihood of ACS. One is statistical probability. They're longer, so there's more areas for it to occur. Core evacuation may contribute to it. We generally don't see it on histology, but we sample every 500 microns. So do longer cores evacuate more than smaller cores? That's not been established. Is the composition of cores different when they're long? Is the center just more thrombogenic? That's not clear, but what we feel strongly about is they have a reduced healing capacity, and we'll go into that a little bit later. But we're not talking again about systemic healing, because not only did our group has shown this as described, but previous other groups have seen multiple TCFA ruptures, but only one will have a clot associated with it, or acute coronary or acute occlusion associated with it, so that we're focused in on tissue healing capacity. So why would core length relate to healing? Well, first, we're talking both about risk of ACS or rupture and healing and containing the rupture. So if you have a long core, you're more like your healing mechanisms are likely to be reduced. And so this study by Kubo in 2010, it is virtual histology IVUS study, so that does have its limitations in identifying TCFAs, but they found the majority of TCFAs became stable plaque. But if you don't have intact healing mechanisms, and again we'll go into why long cores in particular would have poor healing mechanisms, at least in part, then that area is not going to heal. Another study that was done in 2019, and we wrote an editorial for it, is that they were looking at the correlation between healed plaques determined by OCT. In a previous paper, I correlated healing with OCT images and stability, long-term stability. And what they found is in the patients who had multiple sites of healing, more sites of healing, they were less likely to have a future event, whereas those with a lot of healing sites showed few future events or were completely stable. But what's mentioned, though it's not dealt with quantitatively, is that there was a correlation in core length. The ones that had more events had longer core lengths than the ones who had stable plaques. It is established necrotic cores erode the intima, which we somewhat got to in the previous slide. So the larger the core, the more likely it is to erode through. Now, with regard to healing, why would a longer core have poor healing? Well, healing is dependent on having the right cellular mechanisms to maintain the integrity of the intima. That includes synthetic smooth muscle cells. These are referred to as actin negative. They're non-contractile, and endothelial cells are found in clots within a few days. And these two papers illustrate that after a rupture, it takes days to weeks before an occlusive event often will occur. So there's time to establish cellularity in the clot and contain it, and contain the thrombogenicity of that local region. And we're just going to show one example slide. And again, we're going to propose a more significant mechanism for the failed healing in the next presentation. But here we're looking again at a longitudinal histology. There's a really necrotic area on the left in the black box of this 10 millimeter necrotic core, and to the right the red arrow shows a small TCFA with a minimal core that's very unlikely to lead to ACS based on the current hypothesis. But if we look at C, the black boxed area enlarged, in that area where the core is getting near the surface, it doesn't have cellularity. It's a lot of PID and fibrous tissue, loose fibrous tissue, but you don't see a lot of cellularity that suggests a synthetic capability. So again, we're proposing that failure to heal, and particularly failure to heal one mechanism being long cores, is a predictor, or will be a predictor, of acute coronary syndromes. Now, we're fortunate to be, or have been funded by many grants by the National Institute of Health, as well as a grant through the University of New England. And I'd like to recognize collaborators, which there's an extensive numbers, including Maria Rupnick and Frank Willard at the University of New England, the anatomist. Thank you for your time.